And yeah, and we have also a new increase in the number of hepatocellular carcinoma. So hepatologists needs to be quite busy for the next few years. So in Europe, the burden of cirrhosis is quite high. The number of deaths was estimated a few years ago to be 170,000 per year, plus 47,000 deaths from hepatocellular carcinoma. This is a higher mortality than from breast cancer. And this indicates clearly that liver disease has been much neglected by, by, by the governments and the drug companies, because the investment in breast cancer has been 10 times more than in liver diseases. And why people die from cirrhosis? Well, they die from the complications of portal hypertension, mostly bleeding from varices, ascites, hepatic encephalopathy, and these are the responsibles for this very high mortality in the decompensated phase of cirrhosis. So if portal hypertension is so important in the outcome of patients with liver diseases, we should understand the mechanisms leading to portal hypertension if we want to provide a rational therapy for it. And putting it in very, very simple, portal hypertension is initiated by an increased resistance through the cirrhotic liver, which leads to an increase in portal pressure. This is sensed by the liver as something that is preventing blood to circulate through the liver, giving rise to angiogenesis, development of collaterals, and splanchnic vasodilatation. And altogether, this worsens the portal pressure because it increases the cardiac output and then the inflow of blood into the portal system. This increased cardiac output and the vasodilatation give rise to a situation which is perceived by the body as a decrease in effective blood volume and leads to sodium retention and ultimately to ascites and bleeding. Another consequence of this formation of collaterals and decreased liver function is hepatic encephalopathy, and in very advanced stages, it leads also to a low renal perfusion and renal dysfunction. So if we want to know a little bit better about these mechanisms, we have to to consider which mechanisms are implicated in the increased hepatic vascular resistance, and this is the field where more advances have been done in the past recent years. The intrahepatic resistance has two components. One is structural, inherent to the alterations in the liver anatomy caused by cirrhosis, mainly by fibrosis, remodeling, vascular occlusion, inflammation, and the increased stiffness. And the main cell responsible for all these changes is the hepatic stellate cell. This is responsible for about 70% of the increased resistance to the cirrhotic liver. Together with that, there is a dynamic component which is caused by an increased hepatic vascular tone, which is due to endothelial dysfunction and decreased availability of nitric oxide inside the liver. This leads also to an increased sensitivity to vasoconstrictors, and this imbalance between an increased vascular tone and increased sensitivity to vasoconstrictors further increase resistance by about 30%. And altogether, this is the main factor leading to the increased portal pressure. As collaterals develop, the collaterals have an increased resistance to flow as well, and so they not normalize portal pressure because this is not a portocaval shunt. It's much longer, has a diameter which is less than that of a shunt, and have a wall thickness that has importance both in terms of having contractile muscle fibers and also preventing the collaterals to develop as varices. Only they develop varices in areas, specific areas where anatomical circumstances favor that transformation. Together with that, we have this increased blood flow due to splanchnic vasodilatation, which is promoted by increased nitric oxide, increased carbon monoxide and hydrogen sulfide, increased levels of some gastrointestinal peptides such as glucagon. It has also been postulated that endocannabinoids can play a role, and also bacterial translocation is postulated as one of the factors contributing to the vasodilatation through a stimulation of inos through the TNF alpha. This altogether leads to this increase in portal pressure that is responsible for the complications. These mechanisms, we can classify them grossly into intrahepatic targets, so trying to modify all the intrahepatic aspects that we have been outlining before. So it's hepatocyte injury, fibrosis, endothelial dysfunction, and increased hepatic vascular tone and inflammation. And extrahepatic targets such as the main is splanchnic vasodilatation and decreased sensitivity to vasoconstrictors, together with bacterial translocation. And all these targets can be more or less addressed with drugs with more or less success. And I will summarize the new aspects that we have on that field. So, but before that, we have to remember that cirrhosis in its progression passes through two main stages. One very long stage of compensated cirrhosis, bridging from the stage of chronic liver disease and end-stage cirrhosis, which is mainly asymptomatic. And the only thing that can happen during this stage is to develop esophageal varices, but without bleeding. Then, when portal hypertension becomes clinically significant with an HPG above 10 millimeters of mercury, cirrhosis can decompensate and give rise to its complications by order of frequency. The first, the most frequent, is ascites. The second is variceal bleeding, and the third, encephalopathy. And from this decompensated stage, it can further deteriorate to death, quite commonly through acute and chronic liver failure. So this is all this transition in the severity of cirrhosis. And the aim of therapy in the compensated stage is not the same as in the decompensated stage, because in this compensated stage, what we want for the patient is to prevent all these consequences of portal hypertension and keep him asymptomatic, so to prevent decompensation. Whereas in the decompensated stage, you want to prevent acute and chronic liver failure, liver transplantation, and death. So these are the primary endpoints when the patient has decompensated. And this is very important, because if not, we are not really sensing the severity of the disease and the real outcome. For instance, prevention of the first bleeding in patients that are compensated is only a secondary endpoint, because if we prevent first bleeding but we worsen ascites, we will do nothing good for the patient. So the main endpoint should be to prevent the compensation. Whereas in the compensated cirrhosis, to prevent another episode of ascites is not so important. What is important is to prevent things that can be lethal, acute and chronic liver failure, or death. So these hard endpoints are very important for the design of clinical trials, and this has been recognized only recently, since the last Baveno that was in 2015. We will have another Baveno this year in October that will update these concepts. So this slide shows the fact that I outlined at first, that you need an increase in portal pressure over 10 millimeters of mercury to enter the stage of the compensation, at least 10 millimeters of mercury. So if you have a large population of patients, such as in this study, this was the Timor study, where patients all had HCPG measurements at baseline and were followed up to for 8 years, you see that patients who were up over 10 millimeters of mercury had a much greater chance of decompensating than patients who were at less than 10 millimeters of mercury. You see that it's a 90% predictive value, it's negative predictive value. So, and the more independent predictor, the more stronger is an HPG over 10. The second was obesity, and the third was a low albumin level. And the first, the more common manifestation of the compensation was ascites formation. So I want to call your attention now that because of this study, we designed some years ago a new study to prevent the decompensation of cirrhosis with non-selective beta blockers, including only these patients at risk, those with an HPG over 10 millimeters of mercury. So we included patients with compensated cirrhosis, HPG over 10, without varices requiring treatment or previous decompensation, and we divided them according to the acute response to propranolol to receive propranolol or placebo, and in non-responders to intravenous propranolol, we randomized to carbedilol versus placebo. And the study was followed was a follow-up of 5 years for these patients. And the main results are shown here. And it is very clear that in the placebo group, we had a much higher incidence of the compensation than in the group treated with beta blockers. And this was highly significant statistically. And also, the study showed that it was mostly due to preventing the development of ascites, which was prevented in 56% of occasions in the versus the control group. And this was a totally double-blind study analyzed on an intent to treat. And the overall hazard ratio of the compensation was reduced by 50%, which is quite a lot. This study showed for the first time that you can prevent the compensation with such a simple measure as taking a pill, and that this will prevent over 50% of the episodes of ascites, and these patients did not receive diuretics. So you can prevent ascites very effectively by the lowest priced medication in the world, which is propranolol. This is an important consequence. Another thing that we showed is that carbedilol, which is more effective than propranolol, was in this study as effective or more, even more than propranolol. And then we did very recently an individual patient data meta-analysis that confirmed 5 studies that confirm that carbedilol is highly effective preventing decompensation and also in improving survival in patients with compensated cirrhosis and signs of clinically significant portal hypertension. So this is an important message that will be updated in the Baveno meeting next October. So another finding from this study, which is important, is again that the effect of propranolol and carbedilol in preventing decompensation was linked to achieving an over 10% decrease in HGPG. So you saw that patients not decreasing HGPG by 10% are those who concentrated most episodes of decompensation, whereas in patients who had decrease in HGPG over 10%, the compensation rate was negligible. So it is clear that the beneficial effect of treatment is linked to the capacity of decreasing portal pressure. Well, so that brings us again to the first study on propranolol. The first trial on propranolol to prevent, in this case, was recurrent bleeding in patients with cirrhosis. This was in 1981, and now, 40 years later, we are still using propranolol. So it's, I think, a unique example of a drug having survived for 40 years as the mainstay of therapy for a condition. And so it's clear that it has been a major disease modifier, the use of beta blockers for cirrhosis. So here I show you how we can extend the use of beta blockers by selecting patients who require treatment with non-invasive tools instead of selecting by making HGPG measurements. So, for instance, with liver stiffness alone, you have an 80% efficiency in detecting that. If you combine liver stiffness and platelet count, we increase to 85%, and you combine platelet count, spleen size, and liver stiffness, you have these combined indexes that can achieve 88% of efficiency in detecting clinically significant portal hypertension. And there we have new tools, non-invasive tools, such as the shape gradient, which is the subharmonic pressure estimation using contrast ultrasound, which can be as effective as 95%, is almost perfect in detecting clinically significant portal hypertension. So we think that this is the way to go, using non-invasive tests to assess which patients may benefit from this early therapy, and applying this early therapy the best that we can. And the best that we can is by using non-selective beta blockers that will provide safe decrease in portal pressure. And we know that for secondary prevention, we need a 20% decrease in portal pressure or below 12 millimeters of mercury. And in primary prophylaxis with 10%, and in the prevention of the compensation, a 10% decrease, it's enough. And this is very well achievable with the new drugs. So, but don't forget that propranolol does not act only by reducing portal pressure, it also reduces the collateral blood flow very markedly. This explains that axial pressure decreases more than portal pressure, so portal pressure does not explain all the beneficial effects of propranolol. It decreases transit time and permeability, and by this mechanism, decreases bacterial translocation and risk of SVP, and it decreases angiogenesis, which can be related to the reduced risk of HCC that has been demonstrated with propranolol in meta-analysis. So there are several beneficial effects of propranolol that go beyond the decrease in portal pressure. So now we have a super beta blocker, which is carbedilol, which is a beta blocker, non-selective as propranolol, but that has intrinsic adrenergic activity and generates a little bit more of nitric oxide, and it's much more effective than propranolol in decreasing HVPG, as shown in this meta-analysis. As you see, it's very uniform in all the studies that it's much more efficient, and the overall good response, that the 20% optimal response that was observed only in half of the patients with propranolol is obtained in 75 to 80% with carbedilol. It's much easier to adjust the dose, and it's better tolerated, so it's much easier to use than carbedilol, than propranolol. This is true by using the right dose, which is a very low dose of 6.25 to 12.5 milligrams per day. So it's a very low dose. The steps in increasing the dose are only two. We initiate by 3.15 and we increase to 6.25, and that's all. And if the patient feels very well and the arterial pressure is good, you can increase to 12.5. But it's very easy, and we have our nurses titrating the treatment and controlling the patient by phone only. So you reach the full dose in a week. So that's very easy to use. And with that, we come to the new scenario, which is considering cirrhosis as a dual way highway. So up to now, we were considering only the progression of cirrhosis. You show these red lights moving to the horizon of death. And now we are looking at the scenario of regression of cirrhosis, coming from cirrhosis to a non-cirrhotic liver and eventually a liver with normal architecture. How this can be done? Well, this has been shown, I missed a slide here, I'm sorry, has been shown based by etiological treatments. For instance, it was shown first with the treatment of hepatitis B, that showed that several studies showed that you can achieve disappearance of cirrhosis after curing or suppressing hepatitis B virus infection with entecavir. After 5 years, almost no patient is still showing cirrhosis. And in patients with cirrhosis due to hepatitis C, we have shown that even a short-term administration decreases portal pressure, and in long-term administration, and after 2 years of follow-up after the cure of hepatitis C, you have only 40% of the patients who still are above 10 millimeters of mercury, so at risk of decompensation, and I'm sorry, it's here at 2 years on the right group of here, you see that only 47% are still at risk of decompensation, while most of the patients have decreased much more the HAPC. So it is a clear benefit for the patient to be treated, and this changes totally the prognosis of the disease. And this has been proved for hepatitis B, for hepatitis C. It has been proved for patients with NASH using bariatric surgery, for instance, that the liver disease fades up when they lose more than 10% of body weight, and it has been shown for hemochromatosis with chelation, for and for autoimmune hepatitis with immunosuppression. So almost all forms of liver disease will markedly improve or disappear the cirrhosis after treating the etiological factor. And this is mandatory. Another thing which is very important is that a safe lifestyle, making, in this case, we're obese, cirrhotic patients that have an increased risk of progression and death, you see that after 16 weeks of intensive lifestyle intervention program with physical exercise, individualized diet, and so on, we decrease the portal pressure almost as much as with the treatment of hepatitis C. So it's a very important component of the treatment in every single patient. And this is, the effects are mediated by inhibition of pro-inflammatory cytokines and of bacterial translocation. And so abstinence from alcohol, maintaining BMI, and safe lifestyle with activity, physical activity, moderate physical activity, improves the outcome of patients with any form of cirrhosis and should be considered an intrinsic and specific form of therapy for these patients. Let's now go over what we can do to improve fibrosis and cirrhosis by means of drugs aiming at that. I've been talking of removal of injury. This is biologic therapy and healthy lifestyle. This is very well proven. Now we have other factors that can be influenced in this chain of events. So we have to change inflammation to restoration, to improve LSEC phenotype, and to improve hepatic stellate cell phenotype, inducing its senescence, apoptosis, or deactivating them, or improving extracellular matrix degradation. And I put in bold the agents that have been proven to be useful even in clinical circumstances. And there are few, but these are interesting. CALF2 inducers, statins, are effective in the primary injury, in improving LSEC phenotype, and in improving deactivating hepatic stellate cells. So these are very promising drugs, and I will come back to that. FXR agonists, such as obeticholic acid, the new non-biliary acid derivatives of FXR agonists. These are also very interesting agents that have been shown to induce fibrosis regression in humans. And also the pan-PPAR alpha agonist lanifibranor. It's another agent that has been shown to antagonize or reduce fibrosis in human conditions. Much more will come on these agents, and those that are more into clinical practice or closer to be used in clinical practice are statins. But when we use drugs that act on the fibrosis, we have some limiting factors. One are linked to the chemical and physical properties of fibrotic scars, mainly relating to the duration of fibrosis and the degree of disease progression, because when scars become very dense and have a loss of cross-linking, the fibers become so dense that it's almost lacks any vasculature, and this makes this collagen almost impossible to degrade because it has no drug will have access to this kind of patient. And also it could be that there are genetic factors such as the presence of the PNP LA3 allele, lack of HSD17B13 variant, or coexistence of hereditary hemochromatosis mutation, or a form antitrypsin heterozygosis that may favor that these patients don't regress from cirrhosis. And there are other factors that are very important and have already been clinically observed, for instance, in the treatment of FB and FC, that those who don't regress cirrhosis are mostly those who are obese or who have concomitant habits, bad habits such as alcohol abuse. So these other cofactors can be very important in determining a point of no return that's mainly linked to having very advanced cirrhosis. In practice, decompensated cirrhosis is unlikely to regress. What is coming on the horizon right now? Well, as I mentioned before, it is linked to the use of statins, which are all racing morning stars. And statins can be useful for the liver because among the pleiotropic effects of statins, there are ones which are linked to the inhibition of mevalonate formation and therefore of farnesyl and geranyl pyrophosphate that inhibit the production of RAC1 and ROA and induce the and stimulate the expression of KLF2. And linked to these biological effects, we have a reduction in fibrosis, vasodilatation, inhibition of contraction, inhibition of inflammation and cell death, and increase in cellular perfusion and cell survival. These are important factors, important effects, and specifically those linked to KLF2 expression, which is this is a nuclear transcription factor which is activated in normal conditions by shear stress, by the mechanoreceptor complex in the endothelial cells induced by flow, but that is agonisted specifically by statins. So statins induce that mechanism, and this is responsible for the transcription of genes that maintain a normal endothelial phenotype. For instance, INOS, so it's vasodilator and antifibrotic, thrombomodulin, which is anticoagulant and antifibrotic by itself, angiopoietin, which is inhibits angiogenesis, and HO1 and NRF2, which are antioxidants. So by itself, the stimulation of KLF2 already has many favorable effects on the liver. And this has been well shown in many studies together with Jordi Gracia, that KLF2 upregulation or Symbiostatin administration elicits a decrease in fibrosis, as you see here, a decrease in proliferation and this mean marker, and a decreased activation of hepatic stellate cells. And this translates into a decreased fibrogenesis. So it's important, and this is accompanied by a decrease in portal pressure, of course, and an increase in decreased endothelial dysfunction. We also have shown that administration of Symbiostatin can prevent death from acute and chronic liver failure in cirrhotic rats. These are cirrhotic rats treated with vehicle versus cirrhotic rats treated with Symbiostatin, and you see that the prognosis is much improved protecting from the challenge of LPS administration, and the same happens in BDL cirrhotic rats. So this is a strong potential for this type of drugs of Symbiostatin in that case to protect from acute and chronic liver failure. And in men, there are studies showing that Symbiostatin enhances nitric oxide production and decreases the hepatic vascular tone in patients with cirrhosis, so proving that these effects are also achieved in patients with cirrhosis. And in a double-blind controlled trial, it was back in 2009, we already shown that the statins can decrease portal pressure in patients with cirrhosis, independently of being on beta blockers or not, so acting through a different mechanism and improving at the same time quantitative liver function test, which is not observed under placebo. And this offered the possibility, perhaps, of improving survival in patients with cirrhosis. And actually, in the first and only randomized controlled trial, double-blind in patients with cirrhosis treated with Symbiostatin or placebo after an episode of decompensation with variceal bleeding, showed that this increased survival in patients with cirrhosis, but did not reduce rebleeding. So the improvement in survival was mostly linked to the beneficial effects of statins, preventing death from bleeding itself and from infections. So preventing acute and chronic liver failure after complications of cirrhosis. And the effect on death was very important. It has a ratio of only 0.38, means over 60% protection from death in this study. Also, there are epidemiological studies showing that the use of statins can protect versus non-alcoholic steatohepatitis in at-risk individuals, as this study from Italy showed some years ago very nicely, that statin use was reduced the risk of steatosis, of NASH, and of severe fibrosis in patients with NASH. And also, another study, this in case in patients with hepatitis C, showed that in those with cirrhosis due to hepatitis C, it led to a lower rate of decompensation and a lower death rate. And other studies showed that also it prevented hepatocellular carcinoma and prevented the degradation of, of biliary cirrhosis, to the point that you can ask yourself if it is too good to be true that you can prevent all these effects by just giving statins. But an interesting point is also to consider that not all statins could be the same, since this was in a study in Swedish, the Swedish population nationwide study, which is very convincing. On the risk of hepatocellular carcinoma, you show that this risk is markedly reduced by lipophilic statins, but not by hydrophilic statins. And which are the lipophilic statins? For Symbiostatin and atorvastatin, that are the ones that have been shown to be beneficial in experimental models of cirrhosis and in human disease. Hydrophilic statins, such as rosuvastatin and pravastatin, don't concentrate in the liver, and probably because of that lack these beneficial effects. So probably this reinforces the concept that the best statins for cirrhosis would be Symbiostatin, which is the less expensive one, or atorvastatin, probably. Although direct studies in men only have been those with Symbiostatin, atorvastatin has been shown only in epidemiological studies. So there are other ongoing trials with the statins in cirrhosis. At least 3 that are registered with clinical outcomes are being conducted, and these are listed here. And probably these will have to demonstrate whether this benefit of statins that we have shown in the first randomized controlled trial can be also confirmed and extended to other situations. So there are some drawbacks from statins. Statins may cause liver and muscle toxicity, which is more frequent at high statin doses. It causes self-limited elevation of AST, but this is not a reason to discontinue or to change statins. And marked statin transaminase elevations are very rare and not more common in patients with cirrhosis or with liver disease than in patients without liver disease. So this is important because this is not presence of liver disease is not a contraindication for the use of statins. However, due to increased exposure, doses that are well tolerated by normal subjects or patients with compensated cirrhosis should be halved in patients with child C cirrhosis to avoid an increased incidence of muscle toxicity. For instance, with Symbiostatin, we know that the normal dose that we use clinically is up to 40 milligrams per day. In patients with child C cirrhosis, you should not go over 20 milligrams per day because if not, you get higher incidence, too much incidence of muscle pain or the direct toxicity and risk of muscle necrosis with statins. So, as a summary, we have drugs that have been well established disease modifiers in cirrhosis, which are the beta blockers, and we have the concept that the etiological therapy and a healthy lifestyle without alcohol is key in the treatment of patients with any form of cirrhosis. Carbedilol and other non-selective beta blockers are very well described disease modifiers and should be used more and more in cirrhosis, not less and less by the moment. And there is growing evidence of the beneficial effects of statins, although still further trials are required. And there are new drugs on the horizon of these, although these are a little bit more far away from clinical application, except two, which are FXR agonists and pan-PPAR alpha agonists that probably will be in the scene very soon, in 1 or 2 years more, probably we will have the proof if these are useful for the treatment of cirrhosis. And with that, I will close by acknowledging my co-workers in Bern, the group, the team that was formerly directed by Jaime and now by Emeritus that help me all the time and give me a lot of pleasure to still work actively in liver diseases. Thank you.
Well, thank you very much for this inspiring seminar. It's been clear and very exciting and very challenging. I open the discussion. Is there any question from the audience? Please, don't be shy.
Yes, please. Good morning, Prof. I'm Lori Crocetti.
Good morning.
My question is, how do you feel with elastography, and in particular with spleen elastography in this kind of patients? Because we could not perform so often portal pressure evaluation, and we use spleen elastography as a marker just to avoid some endoscopies in patients with very low.
Yeah, well, I think elastography is a fascinating technique. It's very useful. Although by itself alone, it has a sensitivity of 80 to 83% for patients with clinically significant portal hypertension. So it means that you can select approximately the patients who require therapy. In practice, when we use elastography alone, what we do is if a patient has a value over 20, we consider that he has already clinically significant portal hypertension, and we include him in studies or in further studies to treat. If it is only one time that it has been around 20, we wait for a little bit and we repeat elastography. This is the advantage of non-invasive tools. If you combine elastography with a spleen diameter and platelet count in the so-called LPSS index, the specificity and sensitivity for clinically significant portal hypertension increases almost to 90%, which is much more, it's very satisfactory. And for instance, if you use new techniques, that has been reported with the use of SHAPE, which is a new technique. We have an NIH grant to extend the evaluation of this technique. If this is successful, the preliminary data we have is that it can be 95% successful in identifying these patients. So this can be optimal. In practice, however, elastography is quite satisfactory, and if you combine it with simple indexes such as platelet count, and it's enough. For the spleen elastography, there are more limitations due to the fact that in normal spleens, normal size spleens, which are quite frequent in patients with compensated cirrhosis, it is difficult to obtain valid measurements sometime, and with shear wave elastography. So it's and the FibroScan, it's limited for its use in these normal size spleens. So I don't know whether with the new FibroScan for spleen elastography, which I don't have any experience with, this can be improved, but it's only a hope. So probably there will be a number of patients that still escape for elastography. And also in obese patients, we have limitations.
Okay, thank you.
Question? Any other comment? Well, if not, I have a comment. I think that the future, it's really very bright and very challenging. I strongly believe that in a reasonable time frame, we're going to have a way not only to prevent the fact that the chronic liver disease gets from compensated to decompensated, but actually go back to the original dream. If I remember correctly, there was a sort of a large study published by the Mexicans by the use of colchicine, by trying to reduce the extent of fibrosis, actually to reverse cirrhosis and fibrosis. And I think this is the key issue. And I think the statins may provide the key, probably not only statin, but also other drugs together with statins, may provide the key to prevent what you correctly stated is one of the most crucial cause of death, and also cost of a lot of efforts in terms of hospitalization and treatment and loss of work and so forth and so on. So I think that we need to be open and try to remove the dogma that all of us, where we were young, which means yesterday, that cirrhosis is totally uncurable. What you can do is just to treat the complication of the disease. And I think you showed very clearly and nicely that this can be achieved. Do you like to comment on that, Amy?
Well, I entirely agree with you. I think this is the most fascinating field now for people interested in cirrhosis, is to work towards regression of the disease and its clinical and the use of agents that can accelerate regression after cure of the etiological agent, which is something we still don't know very well. And whether the point of no return can be established, and the use of techniques to evaluate the regression of cirrhosis in a non-invasive way. So this is the whole field of cirrhosis in the future will be about that. So it's a very marked change what we will have for the future, and I foresee plenty of studies and a renewed interest in this field in the next coming years. Because
well, I agree. But
yeah.
if I can comment further, I think what we need most in this in this field is to have sensitive biomarkers, because you can do whatever you like in a randomized clinical trial, but the real clinical life is different. So I think, and I wonder whether you ever thought the possibility to move forward what is now the frontiers of new biomarkers, which are Myrna and all the small coding and short coding RNA to measure and to modulate the genes. And I think that could be something that could provide us an additional key to read what's going on.
Yeah, certainly, and these are areas of very hot areas for research, and we are working on that, working on exosomes and microvesicles from diseased cells to see whether this can be safe biomarkers and specific biomarkers to use. We are conducting studies on genomic transcriptomics and metabolomics to characterize patients who are more prone or less prone to have disease resolutions or disease regression, and trying to characterize if some of these biomarkers can be used to non-invasively to monitor the course of regression of cirrhosis. So these, I think, are fascinating fields that will we have a lot of fun and work, and I think it will be very, very useful for future hepatologists in the next.
I agree. I mean, and that is where probably we Europeans need to get together and try to address using the large number of patients we can have in our databank, the samples we have in our biobanks. I think that's going to be a major effort. And I think that the European community should put a lot of money on that, because this is really important.
Yeah, exactly. I think you're entirely right. And from here, I can only say that we are open to any cooperation with anyone. And I'm firmly convinced that we can only solve these problems through cooperation. And so I'm very open to anyone willing to join us in this effort. So it's
Okay.
something.
Any other question? Well, if not, I understand there is a flight to be. What time is your flight?
Well, it's in 2 hours. It's
well, okay. I mean, considering the traffic of Barcelona, it's safe to go there. Yeah. Amy, thank you very much. We'll get in touch. And I really thank you for this excellent webinar. Next time, when the pandemic is going to be over, we're going to have a real seminar with some food aside. Okay?
Good. Thank you. Ciao. Thank you.
Ciao. Thank you very much. Ciao. Ciao.
Bye now. Thank
Bye
you.
now. Ciao, ciao.
Ciao, ciao.